So with that, I would like to just spend 1 or 2 minutes just talking about the epilogue. There is a saying about that you start with the end in mind. For those who are familiar with Steve Covey, this is a popular thing he says in his 7 Habits of Highly Effective People. So, you might wonder, well, why are we talking about the epilogue? I think it really does bring a sort of context, right, as we go in deeper by our August panelists as they really share more in-depth details that they will be doing. And this is literally just a minute, but I thought it would be wonderful to just read a few words from Dr. Washington's epilogue, and then talk about what she's proposing as we go deeper. She's essentially medical appetite traces a long unhappy history of medical research with Black Americans. The book details how Blacks have been convenient, powerless, maligned, and abused subjects of profitable medical research, and also how their treatment has changed over the years from the slavery period where enslaved Africans were physically forced into painful medical bondage, their bodies forced onto the stage of medical experimentation to lend credence to the claims of Black inferiority and difference, which I would like to propose is still going on today. Literally this year, a few papers have been produced to lend credence to the same claim. Black bodies being conscripted for anatomical dissection after death, Blacks being made subjects of experimentation that serve to denigrate their intelligence or provide distorted justifications for their enslavement. And again, all this really being sponsored and hosted by federal governments and private corporations in the form of large-scale research abuses that range from radiation experiments to biological weapons development. So her book really does a great job of going over these themes, which the details will be expanded on by our panelists. But then she also says, well, where are we today? Is this something that lives in the past, or is this something that's going on today? Because this is why we read this book, this period. This is why we're here today. Is to understand, and this is a quote from the epilogue, that medical abuse is more than history, right? Although less rife, it absolutely is a contemporary reality and an ever-present possibility. And truly, we cannot begin to address and fix and rectify and transform if we don't do this without candor. Because traditionally, what have we adopted? An ostrich-like denial position to a lot of the abuses that we've inherited. And that is part of why scientific racism is still rife today. And so she proposes 4 ideas in terms of change. One is to repair the system of the IRB. Secondly, to stop the erosion of consent. And she actually has a book coming out in January just focusing on number 2. 3 is to institute a coordinated system of mandatory subject education in terms of research prep. And 4 is to embrace a single standard of research ethics. And I want to end on this note because in her epilogue, she does talk about this as in basically the exportation of the medical profiting from dehumanization of Black bodies being exported to Africa. As we look at current studies and proposals and the research that has been done on the continent. And I just really summarize all that in this quote: Africa is not your research lab. And oftentimes, Africa and African bodies have been used in a similar way as she outlines in the book vis-a-vis the African Americans. But truly, the same approach can be noted throughout the diaspora. And so there's a lot of movement around decolonizing global health with a focus on the African continent, and she does talk about this. So with this, these few words, I want to cede the floor to my panelists to then really do a deeper dive and have a rich conversation as we look lens of the end in mind. I wish you and I wish us a wonderful conversation to really expand on a lot of these themes that I just hinted at in these last few minutes. Thank you.
Thank you so much, Dr. Oparah. And I have a few minutes built into the end because we're over a couple of minutes, but we're really okay. So now into the book, I'm going to introduce each panelist before they speak, and each panelist has roughly 10 minutes to speak. So the first panelist is Dr. Rhonda Daly. She received her MD from the University of Iowa As a postgraduate, she also received training at the Health Disparities Research Institute of the National Institute of Minority Health and Health Disparities. She is an assistant professor in the Department of Family Medicine and Public Health Sciences, and she's going to focus on the first 3 chapters of part 1, A Troubling Tradition.
Hi, thank you, and good afternoon, everyone. I'm also the scientific director to the Office of Community Engaged Research that's housed in OVPR. Just wanted to say that too. So I'm going to discuss chapters 1 through 3, which is the chapter 1 is called Southern Discomfort. Chapter 2 is called Profitable Wonders, and chapter 3 is called Circus Africanus. So I may just mix and mingle in between the two, and this is really an informal talk. So I want to talk about some of the things that I've even, I've held some presentations earlier this year, last year, year before, on medical mistrust, but this book nicely puts the reasons why that medical mistrust is so high in marginalized groups, especially African Americans, are the enslaved that came from Africa, as we are descendants of them. And chapter 1, when Southern discomfort is talked about, most Africans, they of course arrived on slave ships, and most of them came from in America into the South. Now, the majority of Africans actually they went to South America, and America only got a small portion of the Africans that we see here today. And a lot of them came from West Africa, many from Nigeria, and some of the Western countries there. So a lot of traditions and some and a lot of the culture that was brought from the enslaved to the Americas was even seen in the South. And I'll focus on that a little bit better because it's an important thing, because a lot of the medical experimentation and all of our medical advances now were made at the expense of Black people that came from African nations. And I must say, even gynecology and what they do today was especially a part of that. And even some smallpox vaccinations were a part of that too. But the funny thing about it is that there's a mixture of being ethical and then doing these experimentations, which weren't ethical at all. A lot of the experiments that were done on slaves, they were done without anesthesia. They were done in the presence of no type of hand washing or sanitary conditions. It was in the South. There was many diseases in the South. There is a mixture of people that came into the South, not only from England and the other European countries, but also in Africa and also in Native Americans. So it was a mix of peoples and also infections and things that happened. So a lot of these things that happened in the South and all of the diseases that occurred during there, doctors were interested in actually curing these things or fixing them, because enslavement and slavery was very profitable to the United States. And they wanted to be sure that their slaves were able to work the land. Now, this had nothing to do with them feeling sorry about or being empathetic toward slaves at all. It had everything to do with profit and how that slave and their descendants were going to continue to be to work for their slave masters. For instance, even some of the conditions like the malaria, parasitic infections, and things like that, doctors did a lot of experimentation on them, and the doctors were the ones that were employed by the slave owners. So there's a lot of profit into that. So a slave owner would call a doctor onto the land only when it seemed like the enslaved person was at their deathbed, very, very sick. A lot of times they were labeled as malingerers that were faking their diseases because they didn't want to work. And that could be furthest from the truth, because a lot of times, a lot of the enslaved people hid their illnesses so that they wouldn't be experimented on or taken away, just so they can be inoculated with something, or their blood being leaded by leeches, or given some very, very, very poisonous medications in order to see if they worked. For instance, a lot of things, emetics were used a lot to make people throw up. That was the normal medicine that was used for doctors back in the day. But a lot of the, slaves weren't afraid of being experimented on. It's how they were experimented on. Don't get me wrong about this, because a lot of medicines came that Africans, especially the healers from Africa, they brought a lot of the herbs or their knowledge of herbs to America. And they actually healed a lot of the slaves when they were allowed to do it at the time. So it was the way that the enslaved actually was treated. So for instance, a lot of experimentation again happened with anesthesia. It even James Marion Sims, who's supposed to be the father of modern gynecology, he was actually a sadist. If you can think, that's the best word I can describe to him. He conducted nightmarishly painful experiments on African women. And he started off as a mediocre, indifferent student, went to medical school for just 1.5 years, and that was normal back in the day. And even he experimented on newborns that had tetanus. So newborn tetany is really a result of the Clostridium tetani bacteria that was very common where the slave quarters were, because they normally were where all of the animals were kept. And when the baby was swaddled, blankets and everything were dirty, which made the baby sick with this condition. But he thought that this was due to the mother, or the fact that there was something wrong with the skull and the brains of the tiny infants. So he experimented on them by cracking open their skulls with the cobbler's thing and thinking that their skulls were too small, and they healed much faster than white skulls, which rendered the baby, of course, they died a lot of times, or the baby was very, very maimed at the time. Also, he blamed a lot of the women that he experimented on. He thought that they could really, really handle all of the pain that was induced on them, and that we had a very high pain tolerance, which wasn't the truth at all. And even Anarcha, one of his 17-year-old slaves, when she gave birth, this was the first time that he was introduced to the fact that, perhaps I can make some money out for this, because she developed a vesicovascular fistula, which is from the fact that he used forceps to help deliver the baby. Now, the vaginal fistula is a opening between the vagina and the urinary tract, which is the bladder. And so, of course, that causes very much pain when a person urinates. So he decided that he was going to go and heal this, because it happened in a lot of women, not just African women, but also the American women. But he didn't experiment on the white women. He experimented on the Black women with no anesthesia at the time, even though later on, ether came up as an anesthesia for that person. And so, again, these fistulas are emotional, and they're socially devastating. So he thought he had to make a profit off of those experiments themselves. And also, some of his experimentations were called into question later on by other doctors who looked at this information and said, was this all worth it? And most of these doctors also realized that a lot of the experimentation that happened, really these women still weren't healed, and they still were having difficult problems with these fistulas. There's another doctor that performed cesarean sections on women. He had 4 deliveries, and the first successful C-section was on a person who was giving birth for the first time, a primipara. That's what we call them in medicine. And out of the 36 cases, 29 of them were performed on Black women. There's Dr. Ephraim Dowell, who performed ovarectomy, which is removal of an ovary, on 4 enslaved women. He did it in a state in Kentucky where there was few African Americans there, but everyone used African Americans as experiments to help bolster their medical career, or it was easy to get them because, of course, they were free most of the time, donated most of the time, or they paid money for them, but they could not resist, nor were their opinions asked of. So a lot of this happened, especially in the South, but in the North, these things also happen, but a lot of times the physicians who actually wrote down a lot of this information in their books, in the experiments. So we have all of that. All of this has been really documented very well by Harriet Washington. And I think she went back and looked at all of these recounts of the experiments that happened in the North when it was frowned on a little bit. Marion Sims, especially, he hid the race of a lot of his experiments that he did, and called the women white that he experimented on, which was not true at all. Later on, his statue has been removed. It was a big statue in New York City that was removed a few years ago. Once everyone found out how his experimentations were really horrible at the time. And I want to say one good thing, and I know I'm running out of time. There's an enslaved African named Onesimus who helped the city of Boston. Actually, the smallpox epidemic was happening in Boston, and he brought back from Africa the ways that he was exposed to smallpox before. And everyone knows that once you get exposed to smallpox, you do not get it again. However, he shared the experimentation that he experienced by what they used to do in his country is take the smallpox, the infection from people that are infected, the pus, and also the wounds, and actually give it to someone, open up the skin and inoculate it in that person. And that person then is now they have a small case of smallpox, but again, they have lifetime immunity. So he helped Boston in that way. And even when the second time when it came on again, a lot of physicians were like, well, wait, we can't listen to this. Who is this African person, and who is this doctor who's not even a doctor, this preacher who's helping to promote him? Why should we accept it? But they relented and said, okay, this has helped so many Bostonians, where only 1 out of 48 who were inoculated died, as opposed to people who were not inoculated, which was 1 in 9. So it really helped. But a lot of this experimentation, I must say, the book is very dense on a lot of actual facts, important facts. And I would employ anyone that's in medicine, anyone that's in research, anyone that's dealing with the community a lot, to read this book. It may take a while to get through it, but it is a treat if you can handle all the stuff. I've learned so much. A lot of the things that she talked about, especially in these first 2 chapters, I even use it for my talk because we especially talk about some of the same thing, the Tuskegee experiment that happened, Henrietta Lacks and the HeLa cells. All of these things are important to talk about and to understand why there's medical mistrust and all of the reasons racially for it. These are things that's been documented now, and we have to embrace them, and we have to learn from them, and now see what we can do moving forward to how to actually, make it better for everyone and understand where that history came from, because a lot of people are not taught about this. I'm learning a lot more about this in the past 3 years. I'm not a new person to the world. So this is also important for people to know about these experimentations.
Okay, thank you so much. It's so hard to break people off. We're sort of in the same room, but we're not together. So I'm going to introduce Dr. Mack. So we'll give everybody enough time, and we'll have time for questions and answers. So Dr. Mack, Alida Mack, received her MD and PhD at the University of Chicago, followed by internal medicine residency at Loyola University in Chicago. She's a third-year hematology oncology fellow in our program, and she's going to focus on part 1, the chapters 4 through 6. Alita, it's
Okay.
all yours.
Hi, so this is like 90 pages in 10 minutes, so we'll move kind of quickly. So chapter 4, you can't read this book, especially chapter 4, chapter 7, without being disturbed. So to kind of pick up on what Dr. Daly was saying, basically the disrespect that was done to Black bodies at the hand of white people, white physicians previously. So chapter 4 is the surgical theater, Black bodies in the antebellum clinic. And so this chapter is best summed up by the idea that a lot of the surgeries that were done, is that one of the things Dr. Daly mentions is about people making a name for themselves with no concern for the terror that was inflicted upon Black people. So there's a story at the beginning of the chapter of a 42-year-old slave named Sam who, owners at the time, they would try to, doctor them up, people up as they could. And if that didn't work, they'd send them on to a physician. And so Sam had a mass in his jaw. The owner tried lots of basically crazy things on him. None of it worked. The mass continued to grow. And he sent him to none other than Dr. Sims, who Dr. Daly was mentioning. Dr. Sims is the father of gynecology. He's the one who was basically trying to repair these the vesicle fistulas on women, the vaginal vesicular fistulas on women. So Sam went there, and Dr. Sims spoke to him nicely, and listened to his stories concerned, had him take a seat, at which time 10 physicians ran out and strapped him down in a chair. Another 15 people came in the room, and they all stood by and watched as they removed this man's jawbone without any anesthesia. Just saying that, it makes you sick. You can't get through this book without being sick. And unfortunately, reading through chapter 4, Sam wasn't the exception, or he was the norm. And so even when you read the reports of this per Dr. Washington, there's no mention of the pain, the suffering, how Sam felt. It was just, we were able to do the surgery and take it out. And so you just have to wonder, well, how did these things get passed on to the people who knew him, to his descendants? Because that sort of idea of the passing on of fear and trepidation of the medical system feeds into chapter 5. Sorry, that's like 2 minutes, but we have a lot of chapters to go over. So chapter 5 is called The Restless Dead. It's anatomical dissection and display. And I love book clubs, everybody. So I feel like you got to read something directly from the book. So here's the book. I think this chapter is best summed up by 2 opening statements she has. The first one is from a book by Harriet Martineau, Retrospective Western Travel. And I don't know what that book is, but the thing that she quotes is that in Baltimore, the bodies of colored people exclusively are taken for dissection because the whites do not like it and the colored people cannot resist. So that's a story. That's kind of a theme of things being perpetrated on Black bodies because you can't resist, right? Even as this chapter goes on, even in death. Then the second thing, the second quote is an advertisement for the South Carolina Medical College that was published in 1831. And this says, "No place in the United States offers as great opportunities for the acquisition of anatomical knowledge. Subjects being obtained from among the colored population in sufficient numbers for every purpose and proper dissection carried on without offending any individuals in our community!" Exclamation point. So she puts forth this idea that for Black people, slavery it went on to them into eternity. There was extension of this because even in death, there was still white control over their bodies. And, when you read through this chapter, it's kind of heartbreaking. And listen, some of this stuff went on into 1970s, right? Especially in Baltimore, where people have stories and concerns that if a family member disappears, did the medical system do something with them? Did they either experiment on them or take their bodies? And so in the 17 and 1800s, Black people had deep concerns about this, about what was happening to their loved ones after death. One woman wrote that as she was passing a cemetery, she's like, I hope I die in the summer and not the winter, because there'll be less opportunity for them to take my body and use it, because it basically wouldn't be able to be preserved as long in the warmth and the cold. And so Black people passed these stories on to each other and these concerns, but they were routinely dismissed by white medical system and white physicians. So she outlines this thing that that there was something to the Black accusations, that there's a tradition, and started like in the late 1700s, early 1800s, when medical training changed and there was more focus on anatomical dissections. And if you're going to do anatomical dissections, what do you need? You need anatomy, you need bodies, but we have to take a step back and look and understand that the way death was regarded in that time period was a totally different thing than it is now. There was a lot of ritual surrounding bodies. Like, most people died at home. The bodies were cleaned. They were laid out at home very lovingly. And people would there was this thing of taking pictures with the bodies, being with the body. Dissection was actually illegal at the time. There was one circumstance in which you could be dissected if you were a criminal, sentenced to execution and dissection, not just execution, had to be dissection also. And that was like, that population was not enough to feed the demand that was coming from the shift into anatomy as being an important part of medical education. And there's so much in this chapter. So let me just say a few more things. One of the things is that as part of medical training, physicians had to learn how to go out to the graveyard and harvest the bodies, dig them up. That was something you actually had to learn how to do eventually. And they only did that, you know which cemeteries, the Black cemeteries, because the white people didn't like it. When they did that, they rose up and said, no, not here. So it's very clearly documented where the bodies came from, because they had to say, no, we got these bodies from Black cemetery, from Black people, because otherwise there would be white uprising. And so one of the things that happened is that they eventually shifted it so that like Black porters were used kind of like as the front men to go dig up the bodies out of the cemeteries, and Black people, they just couldn't resist because what could you do? You didn't have the law or anything else on your side. And so how extensive this was, it was a source of it was a big source of economics at the time. And the South would ship bodies up north. They would put them in barrels that were like labeled like, you know, some kind of pickled food, but it was really Black cadavers going to northern medical schools and hospitals. And then in 1995, the University of Georgia in Augusta, their basement was renovated, and they found, wait for it, 10,000 bones, 10,000 bones that were just kind of like in limestone, layer after layer. They brought in anthropologists, archaeologists, all the people. And so when they did that, they found that 75% of those bones belonged to Black people, even though Black people only compose 42% of the population. So there was no kind of justice or rest for Black people, even in death. So then moving on to chapter 6, diagnosis freedom. The long and the short of that chapter is that, you know, she talks about medical racism. And initially Black people, you know, they were thought to be better slaves because they were stronger, they could tolerate horrible conditions. But in this chapter, they talk about how in 1840, the census was performed, and there was this unexpected finding, which was that they started counting free Blacks versus enslaved Blacks. And when they did that, they found that, lo and behold, the free Blacks, they had more disease, they were mentally unfit, they had all of these things. And this came from what was supposed to be an unbiased study. And so that really kind of put the brakes. It bolstered slavery, right? Like, it gave a reason of like, that it was sort of white benevolence to be saving these poor Black people who were free and doing more poorly. So it bolstered slavery, and it really kind of took the steam out of some of the abolitionists, because how can you argue with the census, which is supposedly unbiased? Long story short, it's a beautifully written chapter, by the way, but long story short, the census was done incorrectly. It was inherently flawed, and then the way that it was analyzed was inappropriate also. When they took those things into account, none of this was true. So that's chapter 6 in like probably a 1.5 minute nutshell, which brings us to chapter 7, which is probably the thing that people know about most of all, which is really the Tuskegee experiment. And even though I thought I knew a lot about the Tuskegee experiment, this chapter is absolutely nauseating. It's called A Notoriously Syphilis-Soaked Race. And so just the highlight of the Tuskegee experiment is that there were 399 men who were basically thought they were being treated. They had syphilis. There was a lot of congenital syphilis in the Black community. They thought that they were being treated for syphilis. They were not being treated for syphilis. They were basically being watched so that they could people could determine the natural history of syphilis, and they also were prevented in not near innumerable ways from actually getting treatment of syphilis with penicillin. Penicillin was figured out in the 1940s to be treatment for this, and this experiment went from 1932 to 1972. And the AMA knew about this, but not once, but twice before the experiment finally ended. Sorry, I went over my time. That's it in a nutshell.
Okay, that's great. That's really a good summary. And as I was reading this book and found out about things happening in the 1970s, I was in high school, and then in the 90s, I was already a doctor, and some of these things were happening. So the next speaker is Dr. Marquita Chambly. She received her PhD in philosophy and agricultural education from Pennsylvania State University. She's Associate Provost for Diversity and Inclusion and Chief Diversity Officer at Wayne State University. And Dr. Chambly will speak about part 2, the usual subjects.
Thank you so much, Michael, and thank you for all of your hard work in organizing this session. So I appreciate having been invited to share a few thoughts about the book, Medical Apartheid. I'm not going to go through, although I admire the work that Dr. Mack just did in a chapter by chapter synopsis of my section, but to offer some of my overall thoughts about and impressions of the content, and then offer some of my own experiences. So overall, I found the book very disturbing. It was another reminder that to some people, Black people are still considered not quite human, that as is indicated in the US Constitution, we are 3/5 of a person. So even today, the racist notion that somehow Blacks don't feel pain the same way as whites do persists, and has been seen in the ways that people prescribe pain medication, for example. So all you need to do is go to the Google and type in Black people don't feel pain for articles as recent as June 2020 that speak to the fact that some white medical students and professionals still believe the stereotypes associated with Black people, such as that Blacks have thicker skin or they have fewer nerve endings as white people and therefore experience pain differently. As was mentioned earlier by both Dr. Mack and Dr. Daly, some of the more atrocious medical experimentation happened on slaves without the benefit of anesthesiology, or anesthetics rather. And that kind of, to me, points to the fact that this idea that we don't feel pain in the same way still persists, and that it's disheartening at best. And I would say that it's life-threatening at worst, that some of these people aren't taken seriously about their pain. At various points in the book, I actually winced in pain. So some of the chapters really describe very brutal, painful experiments that were perpetrated on people. And at times it was difficult to read or actually listen to the book. I had it on the audiobook, which made it worse because sometimes I was driving and I want to pull over to the side of the road and kind of take in what I was hearing. But so not only was the subject matter very dense, but periodically I had to consult the dictionary because some of the language that she used to describe various elements of and various things, very, very well worded. I had to have the dictionary, including iatrophobia, which I had never heard of, which is in essence fear of healers. It had me thinking back to my own experiences, wondering if I, or the pain and discomfort that I was feeling, was being taken seriously by my own doctors, and was the treatment that I received at the hands of doctors and nurses a little extra rough, or did I imagine that I was being treated differently? That's not something that someone who's in the midst of a serious illness or being injured in some way should be thinking about, is whether or not they're being stereotyped. So just a little bit more of my own experiences that, I grew up as a doctor's kid in the 1960s. My father was a general practitioner back in my hometown, South Bend, Indiana. And so he was really the model for me of what a medical professional looked like. He was compassionate and caring. He worked long hours. He worked late into the evenings most of the time. And so that was who I saw when I thought about medical professionals. My own personal experiences with doctors have been a mixed bag. beginning with my first doctor when I was my first grown-up doctor, if you will, so non-pediatrician, who I thought was rude and undesirable. And I asked my parents if I could have another doctor. So even back when I was a kid, which was a while ago, the idea of people not caring for us in the same ways was evident to me even as a young person. But because my dad was a doctor and my mother had been a nurse, they gave me all my vaccinations. And so I didn't have to see a doctor for a long time because anything that was wrong with us, they took care of us. So for that reason, I didn't go to many doctors in my adult life. And so it wasn't until my children were born that I had doctors that cared for me. So I just want to say that to the extent possible, where I can, I choose doctors of color when I can. I've had, white men and white women as doctors, and now I have a Black female physician who, by far, I have the most trusting relationship with any medical professional that I've had. So my section of the book deals with research subjects upon whom all manner of experimentation was done, most often without permission or appropriate consent. Sometimes subjects were simply tricked into a treatment or an experimental procedure. And as Dr. Mack mentioned, a lot of times these experiments weren't even therapeutic. They weren't treating anything. They were just experiments. A lot of time to gain fame and or fortune, which a lot of people got very rich on the experimentation on Black bodies. Much of the research described in the book was racially motivated, designed to provide evidence of Black inferiority. For example, Black women were considered hypersexualized and bad mothers, and as a result, they underwent a lot of sterilization, many of which happened unbeknownst to the victim. So the book talks about Fannie Lou Hamer, who is, of course, well known as a civil rights activist, but part of her story was that she went in to see the doctor for an issue that she was having, and when she came out, she had been sterilized, and she didn't realize it for quite some time. So Black women were birth control was performed on Black women as a means of reducing their reproduction and therefore reducing the Black population. And chapter 8, which is called The Black Stork, deals with that. Black children were stigmatized as having disruptive or violent tendencies, as flawed research was done on them. And that was described in chapter 11, The Children's Crusade, where it talked about the use of Black children for experimentation. One disturbing element that I ran across in my section of the book is that many of the entities engaged in doing these experiments were some of the more illustrious institutions in the country, whether it was Harvard and Yale and Columbia, University of Pennsylvania, and others were involved in, that higher education has been complicit in perpetuating and perpetrating some of these activities in the name of scientific research is troubling. And they possibly continue to engage in ethically questionable practices to this day. My guess is that we simply just don't always know what's going on. So the usual subjects, which is section 2, consists of 4 chapters, each detailing various aspects of experimentation on African Americans, whether it was control of Black reproduction, radiation experiments where people were injected with plutonium or exposed to high levels of X-rays, research on all manner of abuses inflicted on African American incarcerated individuals, people who were in the prison systems. And Dr. Mack talked about people having no control. Nobody has less control in some cases than people in the prison system. And so they have been abused terribly in the name of medical research. And then the harm inflicted on Black children, especially Black boys, the research they were doing, trying to prove the violent tendencies of Black males. So as a non-medical professional, I found myself wondering what kind of training is in place for future doctors and other medical professionals that puts the care back into the phrase medical care. When I read about some of the experiments performed, I found myself wondering what happened to the oath to do no harm. The book is enough to make anyone suspicious of the medical establishment, especially the medical research establishment. So I'm at time just about, but I want to say that, you know, is it any wonder that that researchers are having a hard time finding people who want to engage in research around COVID prevention? They're having a hard time finding Black and Latino subjects for their clinical studies. So it's just a particularly challenging time. So I'll just conclude by saying that Medical Apartheid is not an easy read for a variety of reasons, but it's an important read for would-be researchers, for future medical professionals who plan to engage in any kind of research using human subjects. I'll turn it back over to Dr. Simon, and thank you for your time.
Thank you. Thank you. Thank you, Marquita. That's very well spoken. So our last panelist before the question and answer session is Dr. Peter Lichtenberg. He received his PhD in psychology at Purdue University. He's a professor of psychology and director of the Institute of Gerontology at Wayne State University, and he also co-leads the Michigan Center for Urban African American Aging Research. He will focus on part 3, race, technology, and medicine.
I'm extremely grateful to Dr. Simon and the other organizers for including me on this panel. And the panelists who preceded me were simply stellar, and I learned so much from them, so thank you. Simply, this was one of the most disturbing books I've ever read. The sheer magnitude of mistreatment and torture of Black adults and children was difficult to digest. Harriet Washington wrote such a detailed book that it was one of the most instructive books I've also ever read. I was assigned the final section of the book with chapters titled Genetic Perdition, Infection and Inequity, The Machine Age, and Aberrant Wars. I'm just going to share 3 stories related to the chapters. These stood out to me. Sickle cell misstep. In 1949, sickle cell anemia was the first molecular disease to be detected. The sickle cell gene is recessive, and one must carry 2 of the genes to develop the illness. People with one gene are carriers, but essentially they're very well themselves. This is called having a sickle cell trait. By the late 1960s, the federal government started widespread screening for sickle cell disease. The testing was misused in many industries, and especially in the US Air Force Academy. It was used to discriminate against Black adults. Orthopharmaceuticals did the screening and did not bother, because it did not affect their reimbursement, to differentiate between those with the disease and those with the trait. The National Institute of Health published a brochure saying that as many as 2 million people suffered the disease when actually less than 100,000 did, because they equated the trait with the disease. The US Air Force Academy, which discriminated against carriers of the gene, did not reverse their admission policy until a 1981 lawsuit. The story I chose for Aberrant Wars, Stories of Bioterrorism, is called the Carver Village Project, carried out by the Central Intelligence Agency in the 1950s. Carver Village was a modern 466 unit housing unit that was open to Blacks in Miami, Florida in 1946. In the early 1950s, the KKK began bombing Carver Village. Indeed, it's one of the most violent sites of the civil rights movement. At the same time, in 1952, the CIA decided that Carver Village was a perfect place to take the hordes of mosquitoes that they'd bred and infected, designed to produce yellow fever. This was a Cold War strategy, and they wanted to first test it to see if it might work against the Russians. So they went to Carver Village, and they simply told residents that they were studying mosquito bites. Sure enough, the housing I was plagued by a rash of mysterious illnesses, symptoms of yellow fever, and death. And it wasn't until the 1980s that the truth came out. Interestingly, it was the Church of Scientology's Committee on Honesty in Government that did the research to make this public. The committee painstakingly reviewed receipts for what the CIA was buying and put it all together. Well, we are all thinking about infection these days, and so instead of sharing a story from the book, let me just share just a few facts about COVID-19 and Black Americans. To date, Black Americans have accounted for 21% of all deaths from COVID. When you adjust for age, the death rate of Blacks is actually 3.5 times as high as it is for whites. And the age-adjusted disparity is greatest for Blacks in New York, New Jersey, and here in Michigan. Now, the Detroit Area Agency on Aging has known about disparities in early death for Blacks for decades. In 2000, the Institute of Gerontology was part of their initial Dying Before Their Time report. A study which was replicated, unfortunately, had the exact same findings in 2020, and they recently released that report as well. Thank you again for allowing me to be part of this important panel.
Thank you so much. Thank you so much, Peter, and thank you to all the panelists. We now have some time for questions. It's 5:04. I'd like to end on time at 5:30. We won't hit the full 25 minutes that I first slated, and I'd like to make sure I give Dr. Kalmiras 5 or 6 minutes at the end to talk about where we go from here. So I'd like to start the first question as I look at the chat room and some of the other questions, and I'm thinking particularly of highlighting our female Black physicians. And perhaps, the question is, and perhaps starting with Dr. Daly from me, how does this history affect you, or how does this history sort of inform you as you talk to your patients, as you see patients? And I'm thinking maybe as you see Black patients or patients from other minority groups, what are your tricks or secrets?
Hi, thank you for the question, Michael. I must reveal that I am a full-time researcher and do not see patients right now. But in the past, what I've done when I have seen patients in residency and also in medical school is making sure you let that patient know that, of course, that they're human. It's just a matter of asking them simple questions. How are you doing? How's your family doing? What are you in for? These are simple questions. And a lot of times I think even me as being, in the past, a patient or going to the doctor's office, you'll get a lot more from me if you treat me like you want to be treated, or if you want to see your even family members to be treated in a certain way. You must employ that first. That will help to kind of even level the playing field just a little bit when it comes to the doctor's office, because a lot of physicians have to realize that the patient already is worried about their condition and they want to be healed and they are putting their trust in you. But at the same time, it is a matter of them trusting you as well as you trusting them. And whatever information you can get from them to help to heal them, it's much better if that trust, if the patient trusts you. So you have to figure out ways in order to gain that trust from the patient. It's just not a transactional transaction. It's not transactional at all. You're the doctor, you're the healer, and they have to give you some information in order to get it done. And a lot of times, you have to realize the history of a lot of Blacks is that they've gone to doctors and healers before where their questions are not answered, or they feel that they can't ask the right questions because the doctor is the authoritarian. Or they might not say it, but once they leave that room, they may have been confused about what was said and don't want to reveal the fact that, well, that doctor may think I don't know much, or I'm lesser than because I don't understand the situation. And I try to even tell my family members that you have every right to ask every question you can of that doctor, because they are not the be all and end all of everything. So it is up to you to be your advocate if you don't have anyone to speak for you. And I constantly say that to my mother too. And I even told her tricks in order to get the doctor to, pay closer attention to you. And I myself had to pull the doctor card when I'm taking my kids to the ER. And instead of going through all of that, waiting around, I'd say, okay, I'm a physician, I kind of know. And so all of that is cut down, and they get down to business because this is my child. I don't have time to kind of go through this with you. I understand all the medical jargon. So let's just talk about how to heal her, because we tried everything and I'm here now. So Michael, that is it. I think that mistrust starts off with treating the patient like a human first. And that may be an easy thing to say, to do it, but for some people, it's very hard for them to do that. So.
Well, thank you so much. Let me see if Dr. Mack has anything to add, from your experiences and your training and fellowship.
I do. One of the big take homes, well, I'll tell you the personal thing. This helps me understand my family more, this book, because anytime anyone in our family passes away, we don't leave the cemetery. Someone always stays until they start being covered. And I think part of it is, if you think about how things get passed down through generations, the details get lost, but the sentiment is there. And the sentiment for us is always watch and make sure that like nothing gets disrupted with the body. And so I just wonder about like the history from my family. And then the other thing for this book, which I think intuitively knew, but it really, it validates. I think we have to use this as physicians and care providers to validate our patients. I can't tell you how many Black patients I have who are like, clinical trial, you want me on clinical trial? I'm not a guinea pig, but it's like, and you want to be very, the tendency is to be dismissive, or at least I've done that at times, but this book is a reminder, you know what? You were a guinea pig. And so just like in my family, this got passed down of like, hey, always stay and watch that body and make sure that it's covered and it's actually like in the dirt and nothing funny happens. I think mistrust can get passed down and because of bad experiences. And if you think about how maybe just even 1 or 2 generations ago, you don't talk about all the details. Some things were either so hurtful, or it's just a generation where a time when like you keep your medical history private, but you do pass down the sentiment of like, watch, be mistrustful kind of thing. So it helps me like validate when my patients say that, like, I don't want to be a guinea pig. And it gives us kind of a jumping off point to say, well, what do you mean by guinea pig? Let me talk to you more about like what the trial, you're at least getting the standard of care. We're not doing any kind of like, just giving you a sugar pill or something like that. So it really has kind of helped that way when I'm talking to my patients.
So that's
Michael,
wonderful.
may I also add something quickly?
Yeah, and EGM, I have, please, I really, and highlighting my colleagues, but I also want to throw another question that maybe could segue into as well. One of the questions from the audience was, this may be a long discussion about what changes do we need in the IRB? And maybe you have 1 or 2 highlights for that, but please give your personal comments. That's the most important thing.
Yeah, absolutely. And I would say for that question, I did provide responses. So I've been responding in the chat to the questions, just,
Okay.
So folks can review that. But thank you so much. I think this was a great question. If I may add to Dr. Mack and Dr. Daly. So very quick story recently just happened to me. I just came off service, inpatient service, and I'll be going on again soon. But I was taking care of an African-American gentleman with sickle cell disease. We ordered his pain regimen in a certain way. As you know, patients with sickle cell, he came in because of pain crisis. He was in a lot of pain. These are folks that live with chronic, severe, debilitating pain for most of their lives since they're babies. And so he comes in and he's in a lot of pain. And of course, they require a lot of medications, a lot of narcotic medications to get their pain under control so that they don't suffer really bad complications from sickle cell, which can be life-threatening. And do you know that one night, one of the nights, he did not get his medication as prescribed. The nursing did not give him his nighttime medication. So we came in the morning, he was writhing in pain. We asked everybody, why didn't he get his medications? Why didn't he get his medications? We investigated in the chart. It was clear that the nursing intentionally did not give it to him. It wasn't that he declined or refused it. It wasn't given. And After some investigation, it seemed like the nursing was taking it upon themselves to think that this was too much, and so wasn't giving him what was prescribed without calling us and verifying or any of the other things that should be done. 3 days, this man, despite everything that we talked to the charge nurse, we talked to the nurse, we talked to everyone we could to advocate on his behalf. He was not getting his adequate regimen. And so finally, I had to call the coordinator. I had to go up the chain. And I was very clear. I said, this is an African-American man with sickle cell. He is stigmatized ×2. These are two groups of people, as an African-American man, and then also as somebody with sickle cell, which in this city tends to be the same person that is at risk of very poor health outcomes because of health system bias, not because of them, because of what we're doing. We are not taking care of this gentleman. We are, in a sense, participating in health system bias and structural racism written into the code of the way health systems practice, okay? It is not okay. Don't you know that that very night, all his medications were given as prescribed, and the next morning, his pain started to be better controlled. What it means for having a Black physician or any physician of any background who is anti-racist and who is knowledgeable and aware of the realities of when it comes to the health system, research science, and its relationship, very problematic relationship with African-American and African descendant communities, is that you can advocate with your patients and with the system. You can use the words. You can say, no, this is not okay care. This is inconsistent with our beliefs, our mission, and what we say we do. This is not what this is. That's what it means. You don't have to be a Black physician because there's not enough of us. It's only less than 5% of us. And as Black women physicians, it's less than 3%. So the vast majority of physicians and scientists don't look like myself and Dr. Mack and Dr. Daly, right? So we all have to get on the same bandwagon. And reading this book gives us the language to say, wait a minute, this is not about medical mistrust. This is about medical untrustworthiness. And I think we need to change the language. It's not that folks are mistrustful of us. No, we earned that. And so that means that the intervention is not focused on, well, how do we educate Black people to love us better? No, how do we earn their trust? Trust is a natural consequence of being trustworthy. So we have to begin to have conversations around what do we do as physicians, as providers, as a system, as staff, as researchers, scientists, all members of the healthcare system and medical establishment to earn back the trust of the people that we have harmed and we've injured historically and contemporarily as well. So this is a piece of the narrative. If I was going to change something in our language, that would be it. That we don't talk about distrust and mistrust, because then we go out educating people that already know. But rather we need to look at ourselves and how do we change the way that we operate, change the way we educate, we do research, we partner with community, where we highlight, acknowledge, and we repair injuries and damage that we still haven't done the right things about restored in terms of restorative justice with the community. There's other stories I can share. I can do that later, but hopefully I've made the point.
You know, and we could, of course, continue this conversation offline. And actually, if there's, of course, any question of why I chose my panelists, I think you have the answer certainly in the presentations, and they're certainly all wonderful presentations. I want to make sure I'm addressing the questions, that I'm going to turn it over to, I have one more question, one comment, and turn it over to Dr. Klimaris. What are the medical schools, what are the medical schools doing to update the curriculum for students and faculty that can increase their knowledge? And there's another question that's kind of related to this is, well, how do we, and it probably came from somebody in social sciences or services, saying, how do we instruct our client to find the kind of doctor that will be an, emblem of what Dr. O'Hara is suggesting. Now, maybe Dr. O'Hara is saying we all need to do that. But any comments on those questions? Or maybe, I don't know, Peter or Marquita, do you have any comments about what we should be doing in the medical schools, coming from the more administrative level?
I mean, from my perspective, live up to your oath. I mean, it's been, do no harm and all the other things that you're supposed to do. It really is about doing what you're supposed to be doing. with care and compassion. It's like I said earlier, let's put the care back in medical care and not have it be this exception to have good care. And so as far as people, looking for doctors, I mean, I've fired a few doctors in my time just because they didn't remember my name or they couldn't connect with me and I couldn't connect with them. And so I think, I have the luxury and I have the privilege, so I want to be clear about that too. I have choices. A lot of the folks who this is happening to, like the man in the hospital with sickle cell, if he hadn't had someone there advocating for him, he would have continued to suffer. So I just think we need to medical schools need to teach bedside manner, compassion, basic empathy. That's my opinion.
Peter?
They also need to teach us history.
Yes.
And there really needs to be more anti-racism in the curriculum, because I've read a lot of stuff over the years, but I learned a ton from this book. And that's the kind of thing, combined with role models of all stripes, of how to treat patients from diverse backgrounds. Those two things I think are critical.
So I want to say one or two quick things and let Dr. Klimaris have time, have some time at the end. Now, one thing I want to say is one thing that particularly struck me about the book, and I don't know if anybody else picked up on it, the section on eugenics and the way the white doctors were treating their Black patients. This was picked up by a group of very notorious doctors that had a really major impact on my family and history, in that the Nazis learned a lot of lessons from how we were treating our Black patients. And the whole eugenics movement, which is really covered in a lot of depth in this book, was picked up by them. I think then some of the white doctors, there's some comments in the book about how they were jealous about what the Nazis were able to do with their people that are stuck in concentration camps. So I want to make a quick comment about that. The second point is, of course, I talk about this to whoever will listen to me and talk about a lot at home, and something, one point my 25-year-old son made early on in the conversation, early in the summer, is, "This is a great thing, Dad. Really great to do this, but what are you going to do about it? What are we all going to do? I don't want to just be some privileged doctor sitting behind my screen with my friends and saying the right things." I believe as best as I can, I practice this. I think sometimes the best thing you could do, as I heard, is ask people, well, where are you from? Where do you come from when you meet them? And that opens up so much dialogue with our patients. But I'm going to introduce Dr. Klimaris and let him have a few minutes. Justin Klimaris is an associate professor of oncology at Wayne State University, and he's president of the Karmanos Hospital Network, which includes Detroit, Farmington, and as we heard earlier, 16 cancer centers, plus 9 radiation facilities throughout the state of Michigan, and we are growing. We're moving into Ohio, I understand. He will speak about what the KCI is doing moving forward. Thank you, Justin.
Thank you, Michael, and thank you to all the panelists for sharing not only the words of wisdom from this book, but your own particular insights and experiences that I think all of us in society today are sort of taking a pause and trying to understand our world around us, perhaps in new ways, whether it be through the challenges of COVID or certainly the tragedies we're seeing city after city of racial injustice and the challenges of our time and the election in front of us. One of the things that I was thinking as the panelists were presenting, that I love poetry, and those who know me know that. Naomi Shihab Nye, who's a beautiful poet, has this wonderful line in a poem that's entitled Kindness, how she describes that the thread of a cloth being created as sorrow is being felt and sorrow is being seen, and it's only as you stand back can you see the size of the cloth. And as I listen to the presentations tonight and the stories that have happened on our land to human beings that we all should care about and you stand back and see the size of the cloth. What I believe we must do, and I believe I have particular responsibility, and any of us who are in leadership positions, is to bring attention and resources to these challenges, to recognize that the communities we serve are in deep need. And that need goes beyond the physical conditions that we treat and the resources that we try to bring to bear to treat for Karmanos, our cancer patients, but also to understand our communities, to understand the people who bring their talent to work every day, how we create a diverse and inclusive and equitable workforce. I know I saw some of the questions that were being asked about that. I think, frankly, until leaders don't all look like me, a bald white guy, we're not going to have the realization of so many of the things that are necessary. So I think we have a duty as an organization, as a cancer center, as providers, as a health system. On behalf of McLaren Healthcare, we're working very hard as an organization to not only develop diversity and inclusion activities and committees, to bring this into our hiring practices, to bring this into training curriculum for all of our staff, all of our medical students, and those who come into our facilities, but also to recognize that those who we do business with, contracts that we give, all of these things are part of the ecosystem that we all must be committed to make a difference toward. Many of the members of our Diversity Inclusion Committee are on this panel and have supported this effort, and I want to thank them. We're just getting started. I was a physician myself, a medical oncologist. I trained in Baltimore, and I remember on our tour walking in to the old dome of Hopkins and being told on my first day that the statue of Jesus was there to really help bring trust to the city of Baltimore, where all of these things were taught to us, that the fears of death that happened in our cancer centers, of how quickly patients could be taken to funeral homes and out of the building, because there was still concerns then about the injustices of the past in the city of Baltimore. So I feel this deeply personally myself. I thank all the panelists who helped to inspire us today. And please help us to move these issues forward in our community, not only at Wayne State, at Karmanos, but in our health system as we move this forward and improve our world by understanding and action.
So thank you, Justin. And we have a couple of minutes till closing. So I'm going to say a couple of words and let everybody out early, which I think is always a good thing. So one closing comment, in terms of the book club, for several months, maybe around the COVID time, I've been recommending books to patients depending on the situation. And it seems like this is such a nice platform where we're all at the same level playing field. We're physicians, we're bus drivers, we're patients, we're Congress people, we're all at the same level playing field reading a book. And and I've really enjoyed talking about books with my patients, and it really makes it more of a sort of interpersonal dialogue. Of course, we cover the reason why they're there. And fortunately, a lot of our breast cancer patients come in for follow-up and they're doing just fine. We have such a high survival rate. So we have sort of the, in a lot of circumstances. And also with the nurses in the breast clinic, we recommend books and we talk about books. So I really am excited about this Equity Book Club. And the plan is to continue this on a quarterly basis. So please, in the question and answer in the chat, please suggest other books. We thought we'd take the most difficult, and I thank Dr. Ophara for highly recommending starting with this book, which is really basically the kind of history behind it. It's our historical book. I'm not going to use it. I'm not going to call it a Bible. And we're going to keep religion out of this. It's our history. But then there's so many other books that we could be reading. And so we hope to be reading on a quarterly basis. And please suggest books. If you'd like to be a panelist, please let me know. And I hope we could continue this conversation, at least in this way. And that, of course, when we read and we talk as a group, this spills out into the hallways and into the cafeterias. And when we're all get together, we have more to talk about and learn from each other. So thank you so much also to the participants. Of course, we couldn't do this with all the wonderful participants for which we could share this, and for your comments and questions. And again, thank you to the committee and to all the panelists. And I think that brings us to the bottom of the hour.
Dr. Simon, we could end on a call to action. Are you okay with that? And that
Oh,
would,
please.
yeah. So I just want to encourage everybody, because I know not everyone got a chance to read the book, but 2 calls to action. Number 1, come up with your own call to action. One thing you're going to do differently as a result of this conversation today. And if you did read the book as a result of reading the book. And if you did not read the book, then your call to action is to read the book and then have one call to action for yourself. But I would really encourage everyone, just one thing, and even if it's talking to one other person in your life about one nugget that you got out of this conversation and or the book, if you read it, that is powerful. It starts with conversations. First, self-education, and having those conversations to start to break those bonds, right? And then gradually it grows. But just one person, talk to them about one nugget that you got out of this conversation. And I wish you a wonderful, wonderful rest of the day. Oh, and vote. The biggest call to action is vote, people. Vote, vote, vote. All right.
That goes without saying. And we had over 100 participants, so we have 100 conversations at least. So that's wonderful. So thank you very much and have a good evening.
Thank you.
Thank you. Bye-bye.
Thank you.